Hello, I'm Dr. Sam Goldhaber from Harvard Medical School and Brigham and Women's Hospital in Boston, and it's my pleasure to welcome you to this editorial, Novel Anticoagulants, a guide for the clinical practitioner. And I'm joined by Dr. Jean-Pierre Bassand from Besançon, France, from Dr. Stavros Konstantinides in Greece, and from Dr. Graham Turpie in Hamilton, Ontario, Canada. And we have so much to talk about today because the field of anticoagulation is in transition, and I think we're at the crux of it now. Let's just spend a minute or so literally discussing the background with warfarin, which has been called the drug that we love to hate. Jean-Pierre, do you want to just give us a little background on this?
Well, warfarin has been the most efficacious treatment for the prevention of stroke, or more generally speaking, systemic embolism in patients suffering from atrial fibrillation. And to tell you the truth, the whole truth and nothing but the truth, I was very glad in 2003 to see that dabigatran made it, because we have lived with warfarin and all the consequences of this difficult drug for years, and I was wishing to finish my professional life without warfarin. And in 2003 we had dabigatran in SPORTIF 3 and 5 that made it. Say, gosh, we'll get rid of vitamin K antagonists, and you know what happened. But still, vitamin K antagonists are here, possibly here to stay for much longer than we believe now. But we are quite glad to have something, a really, really good alternative close at hand.
Very good. And I want to also talk about all of the novel oral anticoagulants. Let's talk for a minute about dabigatran, which is the one novel oral anticoagulant that has been licensed for stroke prevention and atrial fibrillation. And of course, it's made the guidelines both for ESC, and it's part of the American Heart Association updated guidelines from 2011. Stavros, tell us, what does dabigatran have to offer above and beyond warfarin for stroke prevention and atrial fibrillation?
Well, I agree with Jean-Pierre Bassand that after 2003, when we had the first data on dabigatran, and then were disappointed that then for a couple of years nothing happened, and in 2009 we did have a major breakthrough with the RELY study, and which had excellent results, and perhaps unexpectedly excellent results. And well, since then, dabigatran is not only, as you said, the only approved drug in the United States, in Canada, and in Europe for atrial fibrillation, for stroke prevention. It's also the drug which has the most extensive literature and side aspects of RELY to this point. And we can say that the drug, particularly at the high dosage, which in my opinion was correctly approved by the FDA, was shown to be superior to warfarin. This was much more modest in the beginning, when everybody was hoping to develop a new drug which would be more convenient, and say non-inferior to warfarin. So it was superior. It was and is still the only drug that also reduces ischemic stroke, not just hemorrhagic stroke and intracranial hemorrhage. And it is a drug which in the high dosage, and when of course there are specific precautions in some high-risk populations, probably should be excluded, but it is at the moment a drug which really promises to improve the prognosis, at least the disability, the rates of stroke, the rates of catastrophic bleeding in these patients. So I am certain that this is major progress, and I'm really happy that we have this drug now approved on both sides of the Atlantic.
Fine. Let me ask Graham to talk a little bit about rivaroxaban. The United States FDA has just approved rivaroxaban for preventing pulmonary embolism and DVT in patients undergoing total hip or total knee replacement. and rivaroxaban is about to get a hearing from the FDA for approval for stroke prevention and atrial fibrillation. What does rivaroxaban add in terms of incremental value to warfarin or dabigatran?
Right, I think I've watched the evolution of antithrombotic therapy over the last 30 years, and from the old standards that we're all aware of, heparin and warfarin, through the introduction of low molecular weight heparins, subsequently targeting single coagulation factors with the indirect inhibitor fondaparinux. And now we're in the era of single coagulation factor inhibition with oral drugs. The two main targets are factor 10 and thrombin. Each of one of these targets has its own advantages. Will be debates forever which is better. If we focus on the TENI inhibitors, there are a number of them. In fact, many more TENI inhibitors than thrombin inhibitors. I don't think that's a surprise. You know, factor 10 is the gatekeeper of coagulation. Coagulation can't occur until factor 10 is activated. So it's not a surprise that we have a lot of drugs which target activated factor 10. The most advanced, and the first of these, was rivaroxaban. This is an orally active factor 10 inhibitor, a rapid onset of action. It has a stable dose response without requirement for monitoring. That's the feature of all of these drugs. You know, I think that's the key thing is that they're being developed as an alternative to warfarin for long-term treatment. But they have been tested and maybe an alternative to the parenteral drugs in venous thrombosis prophylaxis. The ROCKET program evaluated rivaroxaban in patients having hip and knee replacement surgery in comparison to the gold standard, enoxaparin, two dosing regimens. In all of the studies, 4 randomized clinical trials, rivaroxaban proved to be superior to enoxaparin without increasing the risk of bleeding. It has all the advantage of being given by mouth without monitoring, and with the trend towards extending prophylaxis after orthopedic surgery to 1 month, this is a big practical advantage over the low molecular weight heparins. Mm-hmm. So we have the efficacy, we have the safety, and we have the practicality. They've also been tested across the spectrum of thrombosis treatment of venous thromboembolism, prevention of stroke and atrial fibrillation, and we can go into that in further detail because exciting information here at the ESC meeting in Paris.
Well, I'd like to expand the discussion, Stavros, and let's just introduce a brief capsule of Averroes and Aristotle in terms of what do they bring to the table, and then we'll open this into more crosstalk.
Well, as Graham Turpie just said, of the factor 10A inhibitors, rivaroxaban was the most advanced, and apixaban was coming a little bit later. So this was, let's say, an interesting strategy to first publish a study which compared apixaban with, let's say, an easy opponent, someone who would lose apparently, because this was tested against aspirin.
Yeah, there's no surprise.
It's not surprise. It's not a surprise. I said no. It's not a surprise.
It's an easy job.
It was an easy job. This is what I was saying.
But it's not so easy if we a priori if we think about safety, because I think the common thought was that aspirin would beat any of these novel oral anticoagulants in terms of less major bleeding.
This is correct, yes. Of course, the criteria for defining a patient as a non-appropriate candidate for oral anticoagulation were a little bit subjective, and there was a lot of room for discussion. Well, in any case, the good news was, and of course not unexpected news, was that apixaban, which was much more efficacious than aspirin, actually the difference was very similar to the difference we had in the past in the head-to-head comparisons of warfarin versus aspirin in stroke prevention. And the good news, as you said, perhaps more unexpected or more favorable was the fact that this was not done at the price of a high bleeding rate, major bleeding rate.
I mean, did any of you expect that the two drugs would be comparable in terms of bleeding before the Averroes results were published?
Well, personally, I didn't believe that there would be less bleeding with an oral anticoagulant, whatever it is, compared to aspirin. And this came to my surprise. But if we talk about apixaban and look, if we broaden a little bit the perspective about apixaban, it's a very, let's say, striking development. If you compare the development of apixaban in acute coronary syndromes and in the setting of atrial fibrillation, is completely different.
It is.
And I thought, honestly, I'm at the end of my professional life, and I was always wrong, just like Graham. I thought that apixaban was dead after the phase 2 trial in the setting of acute coronary syndromes, showing that there was very little room for further risk reduction for ischemic events and quite high room, some space for higher risk of bleeding. And eventually the phase 3 was stopped for lack of efficacy and excessive bleeding.
Whereas Averroes was stopped because it was considered unethical to deny apixaban and to continue the trial because the stroke rate was so much lower with apixaban than with aspirin.
And I thought this drug is dead. And to my surprise, Averroes and now Aristotle are very exciting results.
Tell us about...
Which means that what matters is, of course, the selection of the patient, the pharmacodynamics of the drug, but also the selection of the dose.
And also perhaps the thrombotic illness that we're treating. Stavros, introduce Averroes. You've talked about it. Now introduce Aristotle.
Yes, I would like to begin by saying that Averroes actually was performed in a patient population which is debatable, because according to updated guidelines, it's really debatable who should receive aspirin for atrial fibrillation. I mean, probably those with a CHAD score of 1, probably nobody. But now, so it was, of course, if the physicians say someone cannot receive warfarin, which, as I said, can also be discussed. Well, in any case...
Stavros, what you're saying then is that really Averroes didn't identify the patients who should get apixaban.
Apixaban, absolutely. And actually, the updating of the guidelines, for example, the European guidelines, appear to make this study obsolete, at least in part. But now we have a real-life population. We have the population we need, those patients who are candidates for warfarin. So the question is, if we have a drug which is at least non-inferior to warfarin, if the drug is perhaps...
Talk to us about Aristotle.
So Aristotle...
But before you do, let's digress half a minute and tell us about the Greek origins of Averroes and the Greek philosophy of Aristotle.
So Averroes was not Greek, but Aristotle is a Greek philosopher indeed. He was a student of Plato, and he was the observer among the philosophers. As you probably know, he has written a lot of books about starting from the observation of nature, of the laws of nature, and also then going into politics. So he was the person who tried. He observed the plants, the animals. So he was an all-rounder in science and philosophy, as it was at that time. So Aristotle, and as you probably know, Aristotle dominated European thinking until the Middle Ages and beyond, until...
now he's back again.
Now he's back again, yes.
So will Aristotle dominate the factor 10 introductions?
Well, the factor 10, so the Aristotle study, and to put it a little bit into perspective and compare it to perhaps a little bit in the design to RELY and the ROCKET study, a large study of about 18,000 patients, like RELY, a little bit larger than ROCKET, a study which is double-blind, double-dummy study, in contrast to the RELY study, which was an open-label study, at least with regard to warfarin versus dabigatran, and a study which showed first non-inferiority of apixaban, 5 milligrams twice daily, with some exceptions for older people and those with renal failure, and 5 milligrams twice daily versus INR-guided warfarin. First, non-inferiority was reached, and then the criterion of superiority was also achieved, was also reached with regard to the primary endpoint. So this is a study which compares to the favorable results of RELY, which perhaps is superior to the results of ROCKET, which showed non-inferiority, but as you know, the problems with the definition of several study populations per protocol versus safety versus ITT made some of these comparisons debatable. So in Aristotle, the superiority criterion was met, and then of course we had a few things that made it, that let us come a step further than RELY. We had a drug now which reduced hemorrhagic stroke. This is okay. This we knew. This also happened in RELY and in ROCKET. We did not have a reduction of ischemic stroke as we had in RELY. This has to be needed. So maybe the effect on ischemic stroke was more moderate. It was like the ROCKET effect, and it was much more moderate than the RELY effect. But we had a reduction of overall bleeding. We had a reduction of gastrointestinal bleeding in sharp contrast to the RELY results. And we had an improvement in overall mortality, a reduction of overall mortality, which is quite impressive. So it appears now that we have a drug that maybe is not as strong at that dosage for preventing ischemic embolism as the dabigatran, but it is efficacious, it's superior to warfarin, it is quite safe. And for some categories of patients in whom probably the dabigatran might generate problems, like the patients with gastrointestinal bleeding history or peptic ulcer.
I think that these data are really quite dramatic and are going to have a very big impact in practice. For the doctor, for the patients, it has an effect on the three things that are of interest. It reduces stroke, it reduces the risk of bleeding, and reduces death. What more could you ask for with a drug in patients with atrial fibrillation?
So does the panel think that's it? We've answered all the questions in thrombosis. Time to move on from stroke prevention and atrial fibrillation? Or are there certain subtleties here that require further dissection? What is the implication for the practicing clinician, assuming that apixaban and rivaroxaban receive licensing approval for use in stroke prevention, atrial fibrillation? Clinicians are going to be faced with a choice: continue on warfarin, which was approved in 1954, or switch to dabigatran, or to rivaroxaban, or to apixaban. What is the clinician with the patient in the office who has permanent atrial fibrillation supposed to do?
Well, if we were living in an ideal world, I would tend to believe that the cardiologist would switch immediately to these kind of drugs. But we don't, and they have a cost. And there will be probably a lot of resistance from the payers where they are. Might be in the US just as the same as in Europe. In other words, we already hear some voices saying, well, for the patient who tolerate well vitamin K antagonists, who are perfectly stabilized, or in countries where vitamin K antagonist anticoagulation is perfectly monitored, like in Scandinavia, it might not be such a high demand for this kind of drugs for the majority of the population. So undoubtedly, I believe that the cost will be a barrier.
But correct me if I'm mistaken, but I believe in the ARISTOTLE trial, the stroke reduction was present at an equal level regardless of the TTR.
That is center.
It's also true in the ROCKET trial.
Because that being the case, although that was the finding for the dabigatran, one would say from the evidence, one would switch everyone and not make it dependent upon the individual TTR. And then I think the other point, though, is we're talking about payers, but aren't we physicians, we're a pretty conservative group. We, as a physician community, don't necessarily jump on and embrace change very much, do we?
But on the other hand, I believe, all this discussion is very important, and the cost effectiveness of the new drugs is important. But I think what changed yesterday with ARISTOTLE is the fact that now I'm confident that the new anticoagulants are here to stay. Now we have 3 very good agents. The last one had excellent results. So they will come into our life and into our practice. It is not a question of whether they will make it. I think they will make it. Of course, we will have to increase cost effectiveness. One aspect is, in my opinion, where we are living, and as Dr. Bassand says, if you are living in the Scandinavian countries or in the Netherlands, then with a TTR of 75% or 80%, most probably, and you have the system in place, there is at present no reason to change as a country, maybe for individual patients. But most other countries are not like the Netherlands for many reasons. Do not have the geography and not have this sophisticated system. And so in these patients, there are really many cases for whom even at the dosage at the price of $9 a day for dabigatran, many patients with a high risk of ischemic stroke, and patients who have a perhaps high bleeding risk under the warfarin, and patients in whom the TTR has not been good, then these patients can and probably should be switched to dabigatran.
Well, we're well over our time limit for this session, but at the risk of going over time, as if we're in a hockey game where it's a tied score, I'm going to ask you each a very tough closing question, but not enough time to really answer it. What further research needs to be done, and what does the future hold? Maybe 15 seconds on each of these, starting with Graham.
Well, I think that what we see is data in sort of broad populations, and there will be individuals in whom some dose adjustment might be necessary. So I think that we now have to look at some special populations, the very elderly, the patients with renal insufficiency, etc. We need to get some more, better handle on whether they're safe in that setting.
Great point. Stavros.
Yes, definitely in the populations named by Dr. Turpie, and also more data from other drugs on patients undergoing cardioversion, and from my part also more data on patients having coronary artery disease and atrial fibrillation, where probably combinations could be useful and safe under certain circumstances.
Jean-Pierre.
I would love to have more data on an issue which is very rarely discussed. What happens in case you interrupt the drug? There will be dropouts, there will be drop-off. And we know already that after interruption of the drug, then there is a rebound. Well, might not be truly biologically a rebound, but there is a recurrence of events. So we have little data, very few data about this, but it's probably not a negligible. We cannot neglect this aspect.
Which also brings up the question of medication adherence, which the U.S. Surgeon General has identified as one of her top priorities as a problem across the United States and undoubtedly the whole world. Even when the doctor doesn't interrupt the drug, the patient does.
Yeah.
Well, I think we're going to have plenty of fuel for additional roundtable discussions, and we are ushering in a new era of anticoagulation. I'd like to thank the panel and our distinguished faculty very much for joining us on this edition of the roundtable. This is Dr. Sam Goldhaber signing off.